Thank you, Chairman. I have nothing to disclose. I'm going to talk the risk factors of pharmacotherapy for storage symptoms after transurethral resection of the prostate in patients with benign prostatic hyperplasia. In men, storage symptoms may occur either secondary to or independent from BPH. TURP may be indicated in some BPH patients. Medication may be needed for storage symptoms not effectively treated by TURP or de novo storage symptoms. Therefore, in this study, we analyzed the risk factors of the use of antimuscarinics or beta-3 agonists after TURP in BPH patients. We retrospectively reviewed the medical record of BPH patients who underwent TURP between January 2015 and December 2016, and all the patients were followed up for more than 6 months after surgery. All the patients received preoperative assessment, including IPSS, PSA, urethrometry, and ultrasound. And the postoperative pharmacotherapy for storage symptoms was defined as antimuscarinics or beta-3 agonist, prescribed 3 months after TURP and lasted for more than 3 months. The exclusion criteria included UTI, bladder tumors, bladder stones, prostate cancer, or other neurological disorders. We evaluated the effect of comorbidities, symptom severity, results of preoperative evaluation, and the TURP-related variables for postoperative prescription of antimuscarinics or beta-3 agonists. About patients' demographic and clinical characteristics, of the 376 patients included in this study, 45 patients received postoperative medication, and the patients with postoperative medication were significantly older than those without. A preoperative history of acute urinary retention did not correlate with postoperative medication, and there were no significant difference in comorbidities and the body mass index between medication and the non-medication group. Regarding preoperative assessment, we noticed that patients with intravesical prostatic protrusion over 1 centimeter tended to use postoperative medication. Otherwise, there was no significant difference in PSA, prostate volume, urethrometry, and the total IPSS between medication and the non-medication group. About the effect of TURP-related variables on the postoperative medication, patients underwent bipolar TURP, tending to using postoperative medication compared with patients underwent monopolar TURP. And there was no significant difference in the weight and the ratio of resected specimen between medication and the non-medication group. Furthermore, we do multivariate logistic regression analysis to find out the independent risk factors for postoperative pharmacotherapy. As a result, age over 75 years, intravesical prostatic protrusion over 1 centimeter, and the bipolar TURP were the significant risk factor for postoperative pharmacotherapy. And the bipolar TURP had a greatest odds ratio of 4.25. In conclusion, advanced patient age, intravesical prostatic protrusion, and the bipolar TURP correlated significantly with the postoperative pharmacotherapy for storage symptoms after TURP. Thank you for your attention.
So any questions from the floor?
I just have a quick question. So what is the conclusion for clinical practice from this study?
Maybe we can, because the significant risk factor is the age, IPP, and the TURP. So maybe before the surgery, we can consult well with the patient to info the possible storage symptoms after the surgery.
But it's less than 10% of the cases you prescribe new medication. The group of people with when the people with medication were 45 out of 400. So it's not so common to prescribe new medications, if I understand the results
Not new
correctly.
medication, because it's the retrospective study. So about the preoperative medication, we don't have enough information, especially the refer patient from other hospital.
Okay.
So
Because I'm a GP, so I don't know that much about operating on patients, but I would expect that you go to an operation if the pharmacological therapy fails. So it's quite logic that there's only 10% of active new treatment after operation, isn't it?
maybe new treatment or continuous treatment, because the preoperative medical history is not very clear.
Okay.
Well, thank you very much.
Thank you.